हॅलो. नाही संपलं 9 वाजता. आता जेवतोय. 9:30ला परत दुसरं लेक्चर आहे. हे बघ मी लाल तिखटाची केली.
हाय निखिल.
Hi Rajiv, how are you? Hi Rajiv.
Hi sir.
Hi, how are you? You're wearing a mask in the house?
Yeah, you just came back from work.
Oh, I see. So you're happy to share your slides, isn't it? All you have to do is share screen and then share PowerPoint. So that's what you have to do.
Okay.
So we've still got 8 minutes to go, but if you want, you can test it.
Okay.
Go back to the top. Yeah, put the first slide on, and then
Okay.
no, the first slide, yeah, and then yeah, just go into play slideshow. You have to play slideshow. Yeah, that's perfect. So I'm going to now.
Sorry.
No, just play slideshow. That's okay. You're doing well. Yeah, that's good. That's good. Just leave it at that.
I want the sound also, Zamir. I've got some voice recorded.
Yeah, everything is getting recorded, sir.
Okay, no, voice. Some of the slides have voice.
Yeah, as long as you don't plug in a headphone, the Zoom will pick up the voice from the motherboard.
Sure, that's good.
So if you're speaking directly to the computer, then the voice will be recorded from the PowerPoint.
Sure.
But if you've got a headphone plugged in or you got a Bluetooth, then the voice will go to the Bluetooth and will not come to the PowerPoint.
Okay.
Okay, we're ready, sir. Sir, have a cup of tea and come back. We'll start at 9:30 sharp, sir.
Yeah.
How are you doing?
Samir, things are opening up in London?
No, sir, not at the moment. Not at the
Even in
moment.
Chennai,
Still.
the things are not opened up. They've extended it 2 weeks. Let us see. Let us see.
But they said something about color zones, isn't it? Red, green, and orange or something
We
like
are
that.
in the red zone.
Oh, you're in the red zone? Oh my God.
And on top of that, they have containment areas, which
Oh
is
God.
where there is a total lockdown. You can't even come out of your gate.
Oh, blimey.
I'm not in that zone, and we are in the red zone. Chennai city is in this red zone.
Sir, you have to take care of yourself, sir, because your
I know.
age
I'm
group
not going.
is a real worry. You really don't know how this thing is going to go.
Nothing much for me to do. Rajiv is there. He does everything. So I don't
He's
need to go physically. And all the cases he's doing, including open, and in fact, the uniportal he's only doing.
Oh,
Totally.
fantastic. Fantastic. That is great. That is great. Sir, my suggestion is when you're starting the lecture, do you have a microphone to speak into? Because your voice is echoing from a distance. Is Rajiv there?
Rajiv, microphone irukka kila. Microphone mari irukka. Yeah. Let me see.
Yeah, if he can get any normal phone, microphone with a headphone, and then when your slide plays with the sound on it, disconnect it.
Sound connect.
Because your sound is reverberating a little bit, probably because of a large room.
How do we connect the sound? It's all right.
If you got any of the iPhone or Samsung
iPhone thing
headphones, the normal headphones, they all have a microphone in it. So it will be close to your mouth.
Sure.
And then the sound won't reverberate. Because we are recording, it would be nice to have a clear recording.
Yeah. He's just gone to get it.
Yeah, sure. Any of your normal phone headphones.
Yeah. So how did all the lectures go?
Very well, sir.
Up to you, man. All the energy you have to do this.
It's everybody's contribution, sir. It is just been so phenomenal.
Nice of you to have taken so much of interest and started this. It's really nice.
Yeah, we are really this afternoon we had a lecture on tumor immunology.
On tumor?
Immunology.
Okay.
Professor Akif Turna from Istanbul, and Akif gave a superb talk on immunology, which not many surgeons will know, you see. So I thought it's good to cover it. And so we spoke a little bit about, all the EGFRs, KRAS and all that. And then we spoke about immunotherapy as well.
1 second, sir.
Yeah, sure.
So can you hear me?
Yeah, I can hear you.
Okay. Yeah, it's okay. It's fine. Yeah. Samir, can you hear me?
Yes, sir, I can hear you very well.
Is the voice better now?
Yeah. There is still a bit of echo, but it's okay. Don't worry about it. We can manage with that. That is good enough. But when your slide comes on which...
Yes,
sir, when your slide comes on which there is sound, make sure you disconnect the headphones.
Okay.
Remember to disconnect the headphones. Otherwise, we won't hear it.
Okay, sure, ma'am. Sure. Is your wife still working? Like,
both of us have gone online now.
Okay.
So most of our practice has become virtual.
Okay.
And she is continuing to do her consultations online. And I'm also, so almost every day, Monday to Friday, we are consulting online. No operating at the moment.
Okay.
Consulting online. So
you are no longer with the regular NHS, no?
Yeah, no. I luckily in January, I went full-time private. So I don't have a commitment to go back.
Okay.
So I am still with Bartholomew's. I'm still with Wellington, but as an honorary for private work, sir.
Okay.
So because they are deploying all the surgeons to COVID-19 patients, so I'm very fortunate that I don't need that salary, sir.
Yeah, I know, Zamir.
Life is more important. As you said, as you
Absolutely.
advised me, life is more important, sir.
Absolutely.
So, yeah, but consultations are going on. Almost every day we've got clinics, sir.
Okay.
So just 2 more minutes, sir, and then I'll start. Is that okay?
Sure.
Yeah. I can also see Dr. Harindra Bedi, who has joined us today.
Hello, Harinder.
He's the speaker for tomorrow.
Okay.
Your microphone is off, Harinder. Dr.
Can you hear
Bedi,
me?
yeah, he can hear you, but his microphone is off.
Okay.
How are you?
Yeah.
How are you spending the day, sir?
Let me know.
I'm with my wife sitting. Yeah, we have become like kids, you know. We have become like kids. Preschool going kids. No homework, no examination. Just eat, sleep, talk to each other, take a walk in the evening in the terrace. I'm having a good time. I've worked for 72 years.
Of course, sir.
Good enough.
Yes, sir.
You know, and I have a guy to work, do the work. And
Yeah, absolutely.
so I don't have to physically go. You won't believe me, I've not got out of my compound for the past 40 days.
Oh my God. but it's good life, sir. You should learn to relax and enjoy this time.
Luckily, Zamir, I was supposed to go for 4 meetings to China, to Europe, to Germany, and then to Amsterdam.
Yeah.
And luckily, the thing, if I got caught there, finished.
Sir, same situation here. I had so much traveling booked, but I managed to land in London at the same time.
When did you land in London? Okay.
All right, sir. So let's start. I'm going to start recording first, sir, before we do anything.
Yeah.
And let me just go live on there. So good evening, ladies and gentlemen. Welcome to another session of Thoracic Gurus. Today it's my privilege to introduce a thoracic Mahaguru, really, not just a guru, but a Mahaguru. He is the guy who has really made a difference to thoracic surgery in India. He's the senior most thoracic surgeon, ex-president of the Indian Association of Cardiothoracic Surgery and the ASCVTS. I love his enthusiasm for teaching, and more importantly, I love his enthusiasm for learning. Even at an advanced age of life, he decided to learn VATS, and then looked into uniportal VATS and things like that. He's always available for new ideas, and that's the beauty of Professor Rajan Santosham. Dr. Santosham has probably one of the largest experience in the globe in tracheal surgery, and we are very fortunate to have him with us today. Professor Santosham, the floor is all yours. Please tell us all about tracheal surgery. May I request everybody to please switch off your microphones, and please do not scribble on the screen because we get lines on the screen, so don't do that. Sir, take it away.
Thank you, Zamir, for the nice, kind words. I'm very, very happy that Zamir is taking so much of interest in the teaching program and doing so many live sessions every day. As you all know, he has been a very, very busy surgeon and has traveled all over the world and taught so many people. I have learned a lot from him in the thoracic surgery, minimally invasive surgery. Then I realized at one point of time that that is not for me, and it needs a younger blood to do bad surgery more effectively. And I still do a lot of open surgery, but the video assisted surgery Rajiv is doing is exclusively. I'd like to say a few words about me. I started developing an interest in thoracic surgery because my father was a TB specialist who had a TB sanatorium and a chest hospital run by me, my brothers, and our children. I was also teaching thoracic surgery, many of you may not know, in the Madras Medical College, where I joined in 19 1964 and retired as a professor and head of department in cardiothoracic surgery in 2005. 41 years. In India, in Tamil Nadu, nobody can serve the government for more time than 41 years. Then, of course, the Santosham Chest Hospital, Apollo Hospital has been very good to me right from the time I started, and the Cancer Institute at AR. Thoracic surgery has been, I've done about 500 cases. The results have progressively improved. Every case has been a new learning experience. Progressively, I have modified my technique to improve results. Attended all tracheal update meetings in Vienna and other places of the world to improve my technique and took personal advice from Grillo. When I started the tracheal surgery, I have never seen any tracheal surgery. There were not much of YouTube videos. So all I had to do was to learn and do the surgery. And I had quite a steep learning curve in the first 100 cases, after which, as I will tell you later, the results have progressively improved. We all know that so far no effective artificial material has come for tracheal replacement. Most of the experiments have been till today a failure. And it will be a great thing if somebody can find out a tracheal substitute which can replace the trachea. That is why technically excellence and technical decision is very important in doing tracheal surgery. We have many landmarks in history of cardiovascular and thoracic surgery. In the 1930s, pulmonary surgery. In 40s, esophageal surgery. 1950s, cardiac surgery. 1960s, tracheal surgery. 1990s, VATS. And 2000 and on, robotic surgery has become very popular. Airway surgery, as I told you, has always been my passion. Pioneer in popularizing airway surgery was Dr. Hermes Grillo from Boston, Massachusetts. Tracheal surgery has developed late in 1960s compared to other disciplines in cardiothoracic surgery. There used to be a 2 centimeter rule in trachea saying that not more than 2 centimeters of adult trachea can be removed. However, in 1964, Grillo showed that more than half the adult trachea can be removed by good dissection, tension-free anastomosis, and release procedures. This is a picture taken in Hiroshima about maybe 25 years ago in one of the Asian meetings where I'm standing with Dr. Grillo, my wife, and his wife. I had a lot of hair at that time, even though it started turning white like Zamir even then. Anatomy of the trachea. The trachea is a conduit between the outside world and the parenchyma of the lung. The trachea is a cartilaginous tubular structure connecting the larynx superiorly to the carina and main bronchi inferiorly. The lower edge of the cricoid cartilage defines the beginning of the trachea. On an average, the length of trachea is about 11.8 centimeters, with normal ranging from 10 to 13 in males. The trachea tends to be shorter in females. The trachea is comprised of 18 to 22 D-shaped rings with anterior and lateral walls made of C-shaped cartilage. An intercartilaginous membrane connects the inferior edge of the upper cartilage to the superior edge of the cartilage below. There are approximately 2 rings of cartilage per centimeter of trachea, and each tracheal ring is an average of 4 millimeters in height. The wall of the trachea averages 3 millimeters in thickness. The histology of the trachea. The luminal mucosa of the trachea is lined by ciliated pseudostratified columnar epithelium containing mucus-producing goblet cells. The mucosa also harbors ducts that connect mucus glands in the submucosa to the surface of the tracheal lumen. Airborne irritants can temporarily or permanently damage this mucociliary escalator. Long-term cigarette smokers, for example, have increased mucus production and defective ciliary function. The trachea is a very sensitive structure. The blood supply of the trachea is segmental, and as you can see, it comes from the side of the trachea and the esophagus from the tracheoesophageal groove.
Sir, can I ask you to just stop 1 second, sir?
Yeah.
Can whoever has scribbled on their screens, can you please remove the scribbles? It's not you, sir. Not you, sir. It's not you. It's the people who are using tablets, because this is a meeting. The scribble is coming on. So please remove these scribbles, whoever has done it. And the other thing is, sir, try to speak without the microphone. The echo is still coming, sir. Whoever is using iPads, there is still a bit of echo. It's okay, sir.
Am I audible now, Zamir?
Yes, sir. Yes, sir, it's okay. Don't worry. Carry on, sir. I'm sorry to disturb you. But can people please remove the scribbles? Okay, sir. Please start again.
The arterial...
I'm sorry, sir.
Yeah, no problems. I mean, the arterial supply of the trachea divided into upper cervical and lower thoracic. The tracheoesophageal branches of the inferior thyroid arteries bring blood from the cervical to the cervical trachea. The thoracic trachea and carina receive blood supply from the bronchial arteries arising directly from the aorta. Relationships of the trachea. The esophagus has an intimate relationship with the trachea along its course. The esophagus begins at the level of the cricoid cartilage and runs towards the gastroesophageal junction along the left posterior border of the trachea. The right posterior border of the trachea runs along the anterior aspect of the vertebral bodies. The right and left vagus nerves travel distally through the neck into a posterolateral to the corresponding common carotid arteries. The right and left recurrent laryngeal nerves are branches of the vagus nerves and function to innervate the true vocal cords. The origin of the left recurrent laryngeal nerve from the neck, it arches when it divides and courses posterior medially just lateral to the ligamentum arteriosum. The right recurrent laryngeal nerve branches off the right vagus distal to the right subclavian artery. The anatomy of the recurrent laryngeal nerve is very important in the surgical anatomy. This is a picture showing you both the recurrent laryngeal nerves, the thyroid, the innominate vein, the arch of the aorta, the trachea, the cricoid, and the thyroid cartilage. Surgical resection and reconstruction are considered the gold standard for treatment of tracheal stenosis. But you must all understand, but it cannot be performed in all patients. Cardiovascular, respiratory, and neurological comorbidities represent an obstacle to surgery, as not all patients with tracheal stenosis are eligible for surgical resection. Situation for bronchoscopic procedures are very useful. Now we come to the etiology. Prolonged ventilation, especially the endotracheal tubes. We used to use the reusable red rubber tubes, which are very toxic. High pressure, low volume cuff, tracheostomy tubes, metal tracheostomy tubes, high pressure, low volume cuffs, corrosives, trauma, and in our country, post-tubercular. Tracheal stenosis can be either simple, When the segment is less than 1 centimeter, involvement of limited mucosa, no cartilage loss, and no tracheomalacia. It is complex when the stenotic segment is more than 1 centimeter, accompanied by cartilage involvement, tracheomalacia, inflammation, scar tissue and thickening, and double stenosis. This is before the advent. When I started tracheal surgery, the CT scans were not very popular. We had to do the tracheal radiograph. The patient is positioned on the left side. On the right side, you can have a nice picture of the air tracheogram just above the metal tracheostomy tube. Now, reconstructed CT scan is excellent, especially to show the length of the stenosis, distance from the vocal cord, distance from the carina, and presence of double stenosis. And of course, 3D reconstruction is very, very useful. Bronchoscopy in tracheal stenosis. It's usual to take measurements from the vocal cord to the top of the stricture, from the bottom of the stricture to the carina, assess inflammation, assess tracheomalacia. In critical stenosis, never force a flexible fiber optic bronchoscope. A rigid bronchoscope with a central lumen is more useful. The end-on view of a rigid and the flexible bronchoscope showing that the rigid bronchoscope has a larger lumen and there is a central lumen which is not present in the fiber optic. This is one of the earlier pictures of tracheal stenosis before and after surgery. Plain X-ray chest may show an eccentric hourglass-shaped tracheal narrowing in a good picture. On CT, this may be seen as an eccentric or non-concentric soft tissue appearing under tracheal cartilage. The outer tracheal wall has normal appearance and with evidence of deformity or narrowing. Dynamic expiratory image show little change in tracheal dimensions. Acute and chronic stenosis may also result from tuberculosis, sarcoidosis, histoplasmosis, and Wegener's granulomatosis. Congenital tracheal stenosis may be ring-shaped or funnel-shaped, and acquired tracheal stenosis is usually due to prior intubation of tracheostomy. Progressive dyspnea and stridor is typically present. Inflammation and pressure necrosis of the tracheal mucosa most commonly occurs either at the tracheostomy stoma or at the level of the balloon, usually occurs 1.5 centimeters proximal to the tube tip. The stenosis usually is about 1.5 to 2.5 centimeters of tracheal wall. Extrathoracic trachea most often is involved. Focal narrowing may be seen if the tube tip presses on one part of the tracheal wall, usually the anterior wall. Acute post-intubation stenosis results in edema of tracheal lumen and intraluminal granulation tissue. The treatment indication: surgical resection, good overall health status, stenotic segments from 1 to 4 centimeters, no tracheomalacia, consent to surgical treatment. Bronchoscopic stenosis, simple stenosis. Nowadays, we are able to dilate even complex stenosis. Inoperable patients due to poor overall health status and comorbidities. Serious malacia with stenotic segments less than or even more than 1 centimeter. Bronchoscopic methods are balloon dilatation, diathermy fulguration, and cryotherapy and stenting. Stents, a metal or plastic tube inserted into an anatomical lumen or airway passage. Tracheobronchial airway stenting is very useful for management of central airway obstruction to improve quality of life. Indication in benign disease, complex strictures more than 4 centimeters in length, benign stricture or stenosis in an inoperable patient, post-transplant airway stenosis, tracheobronchomalacia, therapeutic trial before tracheoplasty, benign tracheoesophageal fistula when it is inoperable. Indications in malignant disease, malignant airway obstruction from extensive compression, endobronchial tumor with residual obstruction with multimodal thermal therapy, mixed endobronchial and extrinsic tumor, loss of cartilage support from tumor destruction, malignant tracheoesophageal fistula for palliation. Types of stents, silicone stents, you have the straight stents, the Y stents, and the Montgomery T-tube stents. This is an example of a silicone stent put in position. Common complication of silicone stents are migration, granulation tissue to some extent, though as not as much as metallic stents, mucus plugging of the stent, and now the pulmonologists are able to fix it with a stitch so that it doesn't slip. Self-expandable metal stents is not used in benign obstructions because in the long term it can cause infection, granulation tissue formation and erosion. Types of stents are covered, non-covered, and Y stents. This is an example of one of my early cases, long time ago, where a metal stent is being put. This is a video of a bronchoscopic metal stent deployment done by Rajan. The guide wire has been passed. A balloon has been passed for dilatation. The stenosis is being dilated by the balloon. And the metal stent has been deployed and is in position. Complications of airway stents: stent migration, stent malposition, granulation tissue, tumor ingrowth, mucoid impaction, infection, stent fracture, bronchovascular fistula, airway rupture, and halitosis or severe foul smell of the breath. This is an example of a Montgomery T-tube in position. You can see the distal trachea and the bronchi. Now the bronchoscopy has been done. You can see the vocal cord and the stent in position. This is a 68-year-old man with papillary thyroid CA infiltrating the trachea, had tracheal resection 12 years ago, presented with recurrent infiltration and stridor, required repeated fulguration to keep the airway patent. A fundamental principle of airway surgeon must always bear in mind the arteries feeding the trachea approach the tracheal wall laterally and vascularize the trachea in a segmental fashion along its longitudinal axis. The segmental arteries supplying the trachea approach the lateral tracheal wall, branch superiorly and inferiorly in a longitudinal fashion, forming an anastomosis with the segments of the arteries below and above. Segmental arrangement of blood flow limits circumferential tracheal dissection not more than 2 centimeters above and below, whereas anteriorly and posteriorly It can be mobilized below up to the carina and above up to the crical. What are the inhibitors of tracheal reconstruction? Suspicion of poor healing, presumed limits of resection, maintenance of ventilation, less incidence of cases for a single surgeon, and absence of effective processes. Anesthetic management, now we have been using the laryngeal mask for most of the cases, fulguration and dilatation, or you can use the ET tube proximal to obstruction when it's a relatively low obstruction. Tracheostomy area can be used for airway maintenance, femoral bypass. All these cases I've done with the help of my cardiac surgery colleague, Dr. Vijay Shankar. And good understanding between the anesthetist and surgeon is mandatory in getting good outcome. This is the laryngeal mask, and we're connected with a swivel connector. The advantages you can see right from the vocal cord up to the carina. Preoperative assessment and planning. Careful preoperative and intraoperative assessment is very essential. CT scan and 3D reconstruction are very helpful, especially in skip lesions. Bronchoscopic assessment is mandatory. Bronchoscopy and CT helps us to take measurements from the vocal cords to the upper end of the stricture and associated inflammation and bronchomalacia, and from the lower end to the stricture to the carina. We have to assess preoperative feasibility of surgery, the length of the surgery which can be resected without tension. It is better to remove less trachea initially, and so we have to be careful so that we have should not land up in two cut ends which cannot be anastomosed without tension. In difficult situations when there is a lot of tension, a Montgomery T-tube is very handy. Excuse me. Different types of approaches. The transverse cervical incision in stenosis from vocal cord to the suprasternal notch, keeping sandbag under the upper chest and hyperextending the neck brings about 3 centimeters of mediastinal trachea to the neck. It is essential to make a skin flap above and dissect it up to the thyroid cartilage anteriorly. The strap muscles are separated in the midline and dissected laterally. Thyroid isthmus is cut, transfixed, and separated close to the trachea using bipolar diathermy to avoid injury to the recurrent laryngeal nerves. Nowadays, it is my practice to bronchoscopically view the stenosis, mark it by a needle, and slowly cut the trachea and carefully separating it from the esophagus without causing injury to the esophageal mucosa and the membranous tracheal mucosa. Mediastinal approach. For lesions up to 2 centimeters above the carina, a sternotomy is enough. For extensive tracheal resection, cervico-mediastinal approach is used, transverse cervical and sternotomy. This provides about 2 centimeters extra length of the trachea which can be resected. A right thoracotomy is useful for lesions below 2 centimeters from the carina. I prefer the right thoracotomy approach, though carinal mobilization from midline sternotomy has been described and used by some surgeons. Tracheal mobilization. I have not been happy about the superior laryngeal release, and I don't do it. Mobilization, because it interferes a lot with swallowing and increases the morbidity. Mobilization of upper trachea is limited posteriorly to the cricothyroid junction. I'll describe it later. anterior and posterior mobilization of lower trachea up to the carina, hilar and inferior pulmonary ligament release, U-shaped pericardial incision of pericardium around the inferior pulmonary vein. This picture shows you the side view of the thyroid cartilage, vocal cord, arytenoid, the cricoid cartilage, and the posterior cricoid plate, and the cricothyroid junction into which the recurrent laryngeal nerves enter. So this area you should never cut. You can even cut the thyroid cartilage if necessary, but never cut the cricoid thyroid junction posteriorly, because you're sure to injure the recurrence, which increases the morbidity of the cases. Carinal release maneuvers. You have to cut the right inferior pulmonary ligament, make a U-shaped incision of the pericardium, starting from the anterior pericardium behind the nerve, vagus nerve, below the phrenic nerve, below the inferior pulmonary vein, and posteriorly up to the pulmonary artery. This allows the hilar structure to advance to about 3 centimeters. Here you see the inferior pulmonary ligament has been cut, U-shaped incision has been made in the pericardium, anteriorly and posteriorly. So the entire hilum is lifted above. On top of it, we release the hilar vessel completely, so the whole right hilum becomes loose. Once the trachea is cut, you prefer to use a flexometallic tracheostomy tube, the yellow tube that you see, into the distal trachea for cross-field ventilation with sterile connections. The endotracheal tube is passed from the upper end of the Murphy side, and it is looped with a silk suture. Tracheal anastomosis. The sutures are held by curved and straight mosquitoes alternatively and held by an Alice forceps so that the knots do not entangle. We have always preferred to use absorbable sutures, 3-0 or 2-0 sutures, coming outside in the lower end and inside out in the upper end, so that the knots come outside. Posterior sutures are tied anterior to posterior. The distal flexometallic tube is removed, and the endotracheal tube is pushed from above and passed distally. Once the anterior anastomosis area is completed, the area is flooded with saline, cuff of the endotracheal tube deflated, and the anesthetist hyperinflates to check for air leak. The neck and chest are closed with Grillo stitch put between the anterior chest wall and the chin. We keep it loose only to prevent hyperextension of the neck. Tight Grillo stitch should be avoided. It is very uncomfortable and can cause spinal cord compression and quadriparesis, which is a dreaded complication which occurred in one of my early cases. Complications which we faced. In our early experience, we had a high incidence of tracheoinnominate artery fistula, 7 in the first 100 cases. In the next 400 cases, we did not have a single case of this complication. This has been achieved by not skeletonizing the innominate artery and keeping the strap muscles flap between the innominate artery and tracheal anastomosis site. Best results are achieved if you can preserve the recurrent laryngeal nerve, and as experience increases, the incidence of recurrent laryngeal nerve injury becomes less and less. Postoperative complications are granulations, anastomotic separation, restenosis, vocal cord dysfunction, hemorrhage, tracheal necrosis, tracheoesophageal fistula, tracheoinnominate artery fistula. This is an example of one of the cases of tracheal innominate artery fistula. There is a distal anastomosis between the cortex graft and the common carotid artery, and we have a Prohit Inhara shunt supplying the common carotid artery. After the graft is completed, the innominate can be ligated. This is Sashank's voice done in GH. Yeah. High tracheal stenosis in airway tuberculosis. This is a 21-year-old female patient with complete collapse of the left lung due to left main bronchus stenosis. Bronchoscopy done in January 2018 showed both tracheal and bronchial stenosis. This was done by Ravi Mehta from Bangalore. The findings were subglottic stenosis 1 centimeter below the vocal cord, length of 2 to 3 centimeters, tracheomalacia below the stenotic segments. 9 months later, presented with worsening symptoms, rigid bronchoscopy, balloon dilatation, and a stent was placed. 9 months later, presented with worsening stridor, mandating intervention. Urgent rigid bronchoscopy was done with balloon dilatation and attempted silicone stenting. Technically not possible because the stenosis, as you will see later, is very eccentric. Completely covered metallic stent was placed. Significant malacia noted below. ATT was stopped after completing 1 year. This is a bronchoscopy done by Ravi Mehta. You can see the vocal cord, you can see the severe stenosis, you can see a diathermy knife which has been used to cut the stenosis. And a balloon has been used to dilate it. And long segment stenosis you can see here, with an eccentric stenosis. The metal tube is, stent is in position, expandable stent. Good position away from the vocal cord. And next month, following bronchoscopy, showed that the metallic stent was in situ, but granulation tissue occurring 30 to 40% of the distal end of the trachea being obstructed. Balloon dilatation of the stenotic segment was done and metallic stent removed to prevent further ingrowth of granulation tissue. On 13 February 2019, patient came to our hospital with severe stenosis referred by Dr. Ravi Mehta. She had to be taken for emergency surgery because of progressive stridor. This is, you can see the long segment obstruction, an extrinsic bump, you can see, and a long obstruction. You can see one obstruction and two obstructions. This is an air tracheogram showing the severe obstruction. This is a CT scan showing complete obstruction of the left main bronchus and complete atelectasis of the lung and severe subglottic tracheal stenosis. The thyroid cartilage also has been cut. You can see the flexometallic tube in position and here. Montgomery tube is being positioned because we wanted to stent the trachea. Montgomery tube in position. This is a pictorial representation showing the thyroid cartilage being cut, anterior portion of the cricoid being cut. You can see the anastomosis being started. And a Montgomery T tube used as a stent. Completed picture seen after the T-tube. This is a bronchoscopy showing the T-tube in perfect position. This is a surgical video of surgery.
Tracheostomy, and he developed tracheal stenosis 10 days. So they did a tracheal reconstruction surgery in 2011. He promptly developed restenosis. Balloon dilatation was done twice. And later a T-tube was put in July 2011. When the T-tube was removed, once again he developed restenosis. Rigid bronchoscopic tracheal dilatation and tracheal stenting using silicone stent was used in the stent. They had tried to remove the stent 3 times. However, every time they removed, the boy developed restenosis and inspiratory stridor. Here's the inspiratory stridor. CT scan with 3D reconstruction showing tight stenosis of the trachea in the mid segment. It is about 1.3 centimeters length, 2.6 centimeters from the vocal cord. The anesthetist is using a laryngeal mask for intubation. A transverse cervical incision is being done. The skin flap is raised above up to the thyroid cartilage, and a sternotomy is being done. Once you do a sternotomy, we are able to see the entire trachea from the level of the thyroid cartilage to the level of the stenosis. You can see the exact area of stenosis there, and here a finger is being passed inferior to the trachea in that groove to mobilize the trachea. A bronchoscope is passed to show the exact site of narrowing to help us decide on the site of incision. This is marked with a needle. A transverse incision is being made on the stenotic segment. It was because of repeated procedure, the tracheal wall was very thick. Now the distal trachea is opened and a flexometallic tube is passed for ventilation. The anesthetist stops ventilating from the head end, and sterile connections are passed and given to the anesthetist. Now we are trying to cut the trachea. It is so very thick that ordinary scissors were not able to cut it. Later, what we had to do was to use a bone cutter to cut the area of stenosis. Now, the trachea is separated carefully from the esophagus. Very, very carefully. This is an important step to our endotracheal tube has been inserted from the mouth, and the tube is delivered through the tracheal opening in the neck, and through the Murphy's eye, a silk stitch is passed so as to pull back the tube whenever necessary. Interrupted sutures are taken in such a way the knots come outside in the lower area and inside out in the upper trachea, so that the knots come outside. The sutures are taken 4 millimeters from the cut end and 4 millimeters apart. Here you can see the last posterior suture being taken. And once we complete the sutures, Sutures are tried from anterior and to posterior, taking care that there is no tension. At this stage, the sandbag is removed so that there is tension-free ligation and ties of the trachea. The sutures are tagged carefully so that there is no confusion. Tracheostomy tube has been removed and the endotracheal tube is passed from the neck into the distal trachea. Now the anterior anastomosis, same way, is completed, taking care not to injure the underlying endotracheal tube. Here again, we tag the sutures so that there is no confusion while tying. Now the suturing has been completed and you can see the stay sutures on either side. The stay sutures are tied so that there is no tension on the anastomosis. Now we are checking for air leak. You can see the anastomosis is complete. We are putting some saline. The endotracheal tube cuff is deflated and the bag is hyperinflated to see if there is any air leak. Once after this, we close the sternum and neck, and this is the Grillo stitch, which is put between the chin and the anterior chest wall. We don't put it very tight and make sure that there is no hyperextension possible. So we try to extubate the patient on the table unless there is a problem. And after extubation, Rajiv is doing an intraoperative bronchoscopy to see for vocal cords and the anastomotic site. Case of tracheal reconstruction and odontoid fracture fixation, a single stage repair. We report a case of 22-year-old girl who met with an accident in the rice mill, whereas dupatta was caught in the machine and her neck was crushed. CT scan showed odontoid fracture. Neurosurgeon tried to fix the fracture, but during the procedure was abandoned because the entire endotracheal tube was lying just under the trap muscles. 3D reconstruction of the CT showed anterior tracheal wall disruption, underwent surgery for odontoid fracture fixation by posterior approach, followed by tracheal reconstruction in the supine position. This picture shows you the anterior tracheal wall disruption, endotracheal cuff covered by strap muscles of the neck. You can see the overinflated endotracheal tube cuff. Where intraoperative findings were overinflated endotracheal tube cuff with the anterior tracheal wall had sloughed off with only strap muscles present anteriorly. Thyroid isthmus was cut and divided between sutures. Cross-field ventilation with flexometallic tube, intraoperative ventilation managed by flexometallic tube to distal trachea. Tracheal margins were identified, separated and repaired. Odontoid fracture fixation. Tracheal injury associated with odontoid fracture is very rare. Bronchoscopic guided intubation is very essential to avoid hyperextension of the neck and causing more injury to the spinal cord during anesthetic induction. 3D reconstruction is very helpful for planning operative strategy. Balloon dilatation in acute tracheal stenosis. This was a 62-year-old female with severe COPD, came with severe inspiratory stridor at rest, found to have severe tracheal stenosis. Evaluated thoroughly with PFT, breathing, breath holding time EBG, considered not fit for surgery.
Planned for tracheal balloon dilatation under cardiopulmonary bypass standby. This is a severe stenosis. Here in the other next CT also you can see the thickening and the stenosis. This is a bronchoscopic picture showing you the long segment stenosis. A balloon has been passed and balloon dilatation has been done, and the bronchoscopy could be easily passed beyond, and she had done well. Extubated on the table, shifted to recovery, nose strided, discharged in a stable condition. Tracheal resection in a child. This is a 3-year-old child from Nigeria. Father was a pediatrician, came with road traffic accidents in May 2019. CPR was done by the father at the site and then shifted to the hospital and intubated in Nigeria. Unable to wean off the ventilator, so tracheostomy tube was done. Unable to withstand tracheostomy and tube removed. In July 2019, found to have tracheal stenosis, for which planned to take the child to USA, but couldn't get visa clearance. Brought to Apollo Hospital in January 2020 for further management. The tracheal stenosis is just proximal to the tracheostomy tube. Measurements: total length of trachea 6.8 centimeters, stenosis 1 centimeter, vocal cord to proximal part of stenosis 2.3 centimeters, distal to the point to the distal point of the stenosis to carina 4.5 centimeters. You can see the pre-operative laryngoscopy showing you the vocal cord moving and a segment of good trachea just below the vocal cord, and which we thought was adequate for repair. This is the tracheostomy tube in position. The tracheal thickened trachea being removed. You can see the gross thickening and narrowing of the trachea, and distal trachea ventilated by a endotracheal plexometallic tube. This is after repair, showing you good vocal cord function. Child was extubated, shifted to recovery. Clear, the voice was clear and intact, discharged on 4th post-op day, and it just showed, and histopathology showed chronic inflammation. Case of acquired tracheal stenosis and tracheoesophageal fistula. 18-month-old male ingested a button battery 7 months ago, removed from the esophagus within 4 hours. Mucosal erosion noticed, aspiration noted 10 days later, and so a Riles tube was passed, bronchoscopy was done, and TE fistula confirmed. Commenced nutrition support with nasogastric feed, jejunostomy, and nasoduodenal feeds. Other milestones were normal. This is the button battery in situ which was removed. Healthy looking child, moderate stridor, nil pallor, icterus, dehydration, cyanosis or clubbing, nasogastric tube in situ. The X-ray showed good air entry, crepitations in the right side with inspiratory V's. This is the large tracheoesophageal fistula and the tracheal lumen which is seen. The bronchoscope could be easily passed into the esophagus, and the esophagoscope could be passed into the trachea. This is the X-ray chest of the patient. Large defect 5 millimeters wide in the right lateral aspect of the esophagus, communicating with the trachea for about 2.5 centimeters above the carina. Bilateral multiple parenchymal nodules were seen, showing the large tracheoesophageal fistula. Intraoperative bronchoscopy was done under GA with a laryngeal mask, and then you can see the bronchoscope, anterior cervical collar incision, division of strap muscles, thyroid and isthmus, mobilization and division of trachea, identification and repair of both esophagus and tracheal fistula, and airway checked, hemostasis secured and wound closed. This is a picture showing the opening in the trachea and the fistula. You can see the flexometallic tube distally, the tracheal opening of the fistula to the left, and the Alice is holding the opening in the esophagus. That is the esophageal opening. The mucous membrane has to be included in each stitch. You have to cut the trachea and go in to have proper exposure and separate the trachea and esophagus carefully without injury, and then do the anastomosis. The child is being extubated. The child was discharged in the third post-operative day, and the nasogastric tube was removed. This is the last case, 11-month-old infant from Oman, strider from the neonatal period with recurrent lung infections, diagnosed to have a VSD and was scheduled to have repair in Oman a month ago. There was difficulty in intubation at induction of anesthesia, and surgery was abandoned. CT done afterwards showed severe tracheal stenosis, hence referred for airway reconstruction surgery, has been on endotracheal tube and ventilatory support right from that time, and he was a critically ill patient with Down syndrome and with a VSD. It was done, Dr. Neville closed the VSD and on cardiopulmonary bypass, came off bypass, CT chest, echo, bronchoscopy, and other investigations. This is the X-ray of the patient, say showing pneumonia. The CT of the patient showing you the tracheal narrowing. This is the operative picture. The trachea has been taped with tape, and now you can see a knife being used to cut the trachea. Umbilical tape has been used. Measurements of the trachea are taken, and trachea has been cut. In this child, 1 centimeter of the trachea with a long segment, etc. Complete ring of the trachea, not a funnel-shaped narrowing. End-to-end anastomosis done, extubated, next flexed, chest X-ray, physiotherapy, and ambulation. So I've completed my presentation. Thank you very much for all of you for patiently hearing, and I would like to take any questions from you. Zamir, are you there?
Yes, sir. Thank you very much, sir, for a great talk. Really enjoyed it. Hello?
Yeah, I'm there.
Yeah, hi, you're there. Okay. So I'll start taking some questions, sir, if that's okay with you.
Sure.
Are you okay for a few more minutes, sir, to take some questions?
I'm okay. I'm okay.
All right, sir. Okay. So one of the first basic question that one of our postgraduates is asking is what is the maximum length of trachea that can be resected?
See, in adult male with a long neck, about 5 centimeters, that is half the trachea can be resected. Whereas in a short, stout female, the length of the trachea that can be excised becomes progressively less. So it depends essentially on the build, height, and the.
Okay. Now, in what conditions of tracheal surgery do you decide to use cardiopulmonary bypass?
When I feel that the patient during intubation can collapse, he may have difficulty in intubation and may develop hypoxia and arrest, because I see patients who develop arrest, you can never do anything about them. Such cases, I always keep cardiopulmonary bypass standby. We give a spinal anesthesia, expose the femoral vessels, open the oxygenator and keep it. Dr. Vijay Shankar is ready. In difficult cases, we even put the cannula and keep it ready. And if necessary, the anesthetist tries to intubate. If he intubates, we don't go on bypass. Otherwise, at least in 4 or 5 situations, we had to go on bypass. Because once you have hypoxia and arrest on the table in an ill patient, that is the end. You can't get the patient out.
And your bypass is femoral-femoral, right?
Femoral-femoral, yes.
Okay, and that gives you good circulatory support for the patient. Okay. Have you ever had an arrest on table?
Yes, I've had.
What do you do in those situations?
And luckily, the arrest occurred by the time I had exposed the trachea, and I was able to immediately, within 1 minute, intubate the distal trachea. One patient arrested, this was one of my early cases, that was one instance which arrested, I couldn't revive, and another patient who pulled off the tracheostomy tube before surgery in the hospital. When we were planning surgery, I couldn't intubate, he developed hypoxia and arrest. These are the 2 cases which I could not revive. One case I could revive. Because once they arrest, if you're not quick, if you're not able to ventilate, you can never get them.
I see. So this is mentioned to the patient in the consent forms, and also the risk of a permanent tracheostomy?
Yes. See, in ill patients, we give them a higher risk on the table. For example, one of the patients I remember came in severe stridor. I was reluctant, but Rajiv said, we'll give him a try. So did a bronchoscopy, quickly put a balloon and dilated, we were able to get away. So we always tell them there is a chance of risk to life is there. And in very sick patients, we give more than 50% risk before we take them up, so that they know the gravity of the situation. It's very, very essential nowadays to talk everything to the patient before you take them up for surgery.
When you do tracheal surgery and you dissect around the trachea, what energy device do you use?
Bipolar cautery and sharp scissors. Unipolar is more dangerous to the recurrent.
Okay. Any role for harmonic or something like that in that area?
I'm not used harmonic, Zamir. I'm sure it should be a good, it can be used. Where Rajiv uses a lot of harmonic in his VATS, uniportal VATS, but I've not tried it. I must read about it and see whether it is superior. See, Zamir, what has happened is over the years, our incidence of recurrent laryngeal nerve injury has come down. So we are happy with the technique that we are following, sharp dissection and bipolar.
So do you actually try to identify the recurrent laryngeal nerve, or do you leave it alone?
I leave it alone.
You leave it
alone. Don't chase it and identify. If I see it, well and good. Otherwise, I don't look for it.
Okay, so there is less chance of injury, because that's one of the philosophies, isn't it? That if you don't go looking for it, you won't damage it. What sutures do you use for your tracheal anastomosis?
We used absorbable Vicryl. Some people use monocryl. I've been very used to Vicryl. Depends upon the thickness. Sometimes 10, 20, 30, and in small children 4.
And just for the youngsters, what is the difference between using a continuous suture versus interrupted
Yeah,
suture?
see, when the tracheal wall or the bronchial wall is very thick and diseased, it is better to use a interrupted suture. But when you have good tracheal wall and it is healthy and not inflamed, not grossly thickened, you can as well use a continuous suture. Two layers of continuous, not one suture all around, one anteriorly, one posterior. It depends upon how the trachea is. Like
And
the trachea was very thickened, so there was no way we could use a continuous suture.
And what are your indications for using a muscle flap on
See, muscle
these
flap,
anastomosis?
one thing for sure, when you think the innominate artery is straddling on the anastomosis, I use a muscle flap. And the tracheoesophageal fistula repair, I use a muscle flap. I don't use a muscle flap in any other situation. Tracheoesophageal fistula repair also, if I'm not happy, I use, not as a routine. But innominate artery close to the suture, I always use a muscle flap. It is usually the strap muscles.
And in a few of your cases, the stricture was very close to the vocal cords. And I saw that you also put in a stent, or maybe the pulmonologist put in a stent.
Yeah.
So what is the safe distance of a landing zone of a stent below the vocal cord?
Distance, it should be, for a good repair, 1.5 centimeters of the below the vocal cord, 1.5. But even for stenosis higher, you can cut thyroid cartilage up to the vocal cord. You can, but posteriorly you should not cut the cricoid. Anteriorly, the cricoid can be cut. And if you have any problem, you make a oblique incision or the trachea above and below. If there is, in very high laryngotracheal stenosis, it is always better to put a stent, Montgomery T-tube stent for some time, which can be removed at a later date. So that is one of the indications for the Montgomery T-tube stent. And when you keep a T-tube stent, the vertical limb should be below the vocal cords as far as possible. If you try to put it above, patient will aspirate.
And do you need to do anything to the vocal cords, like inject them with silicone? And
no, I've never used it, Zamir. I don't know. I'm not had the necessity to use it.
Okay. What is the risk of recurrence with balloon dilatation?
The recurrence of balloon dilatation is fairly high. But the only thing is, in ill patients, you can do it again and again and again. When they are poor surgery, some of them do not want surgery. Some of them are very high risk for surgery. Balloon dilatation in benign stenosis is reserved for these two categories of patients. And the advantage of balloon is you can do it again and again, but in case you fail, and you can explain to the patient and take them up for surgery later. Because by the time they are fed up, they want a permanent answer.
And this dilator is specific for the trachea? Or is
yes,
it the
specific
same
for
one?
trachea. You have different dilators for trachea, different for esophagus. We have
they are not interchangeable.
No, you can use a esophageal balloon if you don't have for a tracheal balloon, but not a tracheal balloon for the esophagus.
All right. And when you do tracheal surgery in pediatrics, what is the effect of growth on the anastomosis that you've made? Does it matter? Does it become stenotic?
It really, it is a very good question. In children and small infants, it's better to never use continuous suture. Because once you use continuous suture, you are causing a fixed obstruction. Whereas when you use an interrupted suture, there is enough normal trachea in between to grow. Anyway, we have to follow these patients up. And I have had I've not done too many children and infants. I've not had any problems. So one patient had a problem, but it was only granulation tissue. Once we pulled it out, the child became moderate.
All right. And the tracheoesophageal fistula that you operated, the case that you showed, what do you do to the esophagus? Do you bypass the esophagus to allow it to heal? Or
no, you cut the esophagus. There is a vertical hole in the esophagus. The right tube is already there. So make sure that you don't narrow the esophagus, lift it up and use continuous suture for the esophagus. And yeah.
And that heals very well.
Interrupted sutures as well.
All right. Okay. Thank you, sir. Some youngsters are asking some questions, sir. How do you decide that tracheomalacia is present?
You have to do it by bronchoscopy. When you do bronchoscopy, when there is significant tracheomalacia, the anterior and posterior walls will come very close to each other. And when during inspiration and expiration, if it remains, you have to do something about it.
And is tracheomalacia irreversible?
Tracheomalacia after surgery, what happens is after surgery, when you make the trachea more taut, most of the cases, the tracheomalacia disappears because you're pulling the trachea from both ends and suturing it. So it becomes more taut and the tracheomalacia problem does not arise. It gets cleared. I've not had a recurrent tracheomalacia after.
Sir, there is a question. They've asked you to please re-explain intubation for tracheal surgery. They just want clarity on that.
Yeah. See, what we do is we use a laryngeal mask. I showed it on the video. Yeah. And then we put a laryngeal mask and connect it to a ventilator, then put a bronchoscope and assess it and see if everything is all right. The anesthetist sees for carbon dioxide retention, whether he is able to blow the lung. And I have not had a problem in so far to replace the laryngeal mask. Last 3 years, we have been using the laryngeal mask in each and every one of our cases. It is excellent. Even for patients with carbon dioxide resection, you put a laryngeal mask like that lady I showed you, you dilate the trachea, the carbon dioxide retention goes away. And difficult situations, you can dilate and then operate. We have to have the entire gamut. The rigid bronchoscope, the flexible bronchoscope, video bronchoscope, dilators, cryo, diathermy, the whole set has to be available. You cannot be running at that time cardiopulmonary bypass. For safety, you have to have the entire gamut and decide what is best for the patient.
Sure. Now, when you use stents in patients, how do they cope with foreign body sensation and resultant cough?
Sorry, I didn't get you.
Yeah, he's asking, when you use stents in the trachea, how do you cope? How do the patient copes with a foreign body sensation?
They always have a foreign body sensation, especially in expandable metal stents. In the silicone stents, it is less. They always get infected. They always have halitosis, especially in expandable stents. And granulation tissue is much more common in expandable stents, as you know, migration, erosion, granulation tissue, tracheosis, than a silicone stent. What the pulmonologists do is they put the stent, keep the stent for some time. They put a stitch to fix the stent through viewing it through the bronchoscope, and they invariably remove it after some time. Some of them, that is enough. Some of them need surgery after that, like this boy who had multiple procedures and needed surgery.
And when you're doing a bronchial sleeve, this is slightly different.
Yeah.
But they're asking, how do you manage mismatch of luminal diameter?
See, like mismatch anywhere like the vascular and things like that. The area which is larger, you have to the sutures have to be little more apart. The area which is narrower, the sutures have to be close. You can't. It has to be adjusted all around and not in the last stitch. In that case, you get a dog earring and stenosis. So when you do that, you can adjust the anastomosis.
So the same question they're saying is, like in bowel anastomosis, you look for vascularity by bleeding, color, and pulsation. How do you identify the cut ends are healthy?
See, when you look at the trachea and the bronchus, you know that the trachea or the bronchus is viable by the appearance. The necrotic trachea or bronchus is dark in color and it is necrotic. It has thick plaques and granulation tissue. When you do airway surgery, you'll be very easily able to see it and identify it. by the naked eye.
Yeah.
And the bronchoscope also helps you to take measurements and look at it even when you're operating.
The next question they're asking is, what should be the surgery for cricoid stenosis and stenosis close to vocal cords?
That is what I was telling you. Cricoid stenosis, you have to cut you can cut the cricoid only anteriorly, but you can cut the thyroid cartilage much more. You can make an oblique incision on the trachea, preserving the tracheoesophageal groove posteriorly and taking out some portion of the tracheal cartilage, make a lip of the lower trachea, V-shaped lip like this, take it up and anastomosis. Only thing is, you must not go beyond the tip of the vocal cord, that's the tip of the thyroid cartilage, because that is where the vocal cord is attached.
Sure. And when you're done, I am presuming this question is about tracheoesophageal surgery. When do you start oral feeds after surgery?
Once the vocal cord is good, you can start it the next morning.
And what is the role for bronchoscopic?
Bronchoscopic assessment is done intraoperatively after surgery, and if necessary only, if you anticipate vocal cord problem, you can do it on the first post-operative day to see for vocal cord movement, to see for granulation tissue, to see the viability of your anastomosis. I usually do not do it as a routine unless it is necessary. I don't like to irritate the bronchial anastomosis.
I see. And there's again, I think this is a question you've already answered, but I'll ask you. They're asking about bronchoscopic dilatation for stenosis. Is there any role?
For bronchial stenosis? Definitely there is a role. Yes, you have so many tubercular patients who come, who have bad disease, who have localized stenosis for a little long. You always try to dilate them first. See how they react. And don't jump into surgery without giving him a trial of balloon dilatation. If they get away with balloon dilatation, you're well and good. If they don't, we can always offer surgery later.
And is it mandatory to use CPB in small children?
Cardiopulmonary bypass.
Yeah.
No, definitely. I'm not never used. The one case they used was VSD. They finished the VSD. They came off bypass, and I ventilated with a tracheostomy tube, endotracheal tube, and did the tracheal surgery. I've never used CP bypass for children, but in congenital tracheal stenosis, world over, in the long sigmoids where they do slide tracheoplasty, they do use cardiopulmonary bypass. I've not had the opportunity. Mine was a ring stenosis, as I showed you.
Sure. And have you had any experience with post-transplant stenosis?
The transplant is done by a different group of surgeons. I don't get involved with them. They use the pulmonologist. I'm not able to answer that question because I have no experience in post-transplant dilatation of strictures.
This question is, he's saying, if intermediate stem bronchus is damaged with loss of tracheal tissue, not approximated by hilar mobilization, do you do a pneumonectomy?
See, unless you are forced to do a pneumonectomy, never do a pneumonectomy. Preoperatively, you will be able to assess it with a good quality CT and bronchoscope. And always you want the patient that if necessary, there is a chance that maybe land up. I have not had to do a pneumonectomy on a patient because we have studied it thoroughly by CT scan, bronchoscopy, good quality CT scans, looking at the bronchial mucosa, and then looking at the CT scans along with a good radiologist. They give us more information. So you may land up. One case I had of a trauma patient who had tracheobronchial disruption. That patient had a loss of bronchial tissue in the bronchus intermedius. Upper lobe could be saved, but the upper lobe could be saved, but the upper row cut into the bronchus could not be anastomosed. There was no tissue distally because it was completely disrupted. That patient on normal breathing had a large air leak to the ICU.
Okay.
You will end up in situations for pneumonectomy.
Yeah,
by and large, try to avoid it.
sure, of course. And do you do slide tracheoplasty?
I have done one case. I have done one case along with Dr. Neville, a slide tracheoplasty. But it's a different ball game. It is done by centers all over the world who are completely concentrating on this. In fact, this child from Oman, they wanted to take the child to Great Ormond Street, but the government did not permit them to go because of the expenses. I suppose the guy from Great Ormond Street, I forget his name, is an Indian guy. He spoke to me and said, "Why don't you do this?" And that's why we did it. For slide tracheoplasty in an infant is an entirely different ball game. You need to have dedicated team of doctors, pulmonologists, anesthetists, and surgeons to handle. I have done just 2 cases. And my experience in this, that we had to do it because there was nobody else doing it in this country. So that I feel if somebody can afford it, nothing like going to a center in the US or UK, which are not specific for this purpose.
Can you do that in adults?
So no.
Predominantly.
Yeah.
Now the next question is tracheoinnominate fistula in long-standing tracheostomy tubes.
I've done a few cases like that. Just 2 cases,
Sure.
along with Vijay Shankar. But nowadays, you have covered stents.
Yeah.
So the role of surgery has drastically come down. Whenever you suspect something, what you need is take the patient to the cath lab, put a covered stent and be done. Because this surgery is difficult surgery. Already the patient is in tracheostomy. Nowadays, we send it to the invasive radiologist for stenting.
Okay. So how do you buy time when the first bleed happens?
When the first bleed up occurs, you can never buy time. The first case that we had was a case for which I did a tracheal resection and anastomosis, mucoepidermoid carcinoma. It was a Sunday evening at 5 o'clock. My friend Vijay Shankar is always available. Luckily, I was also available on that day. We did a CT scan, which showed the tracheoinnominate artery area fistula. So immediately, see, initially there will be bright red blood. If you give time, it is a surgical emergency. You have to do it as soon as possible if you have to have good results. You cannot sleep and do it next morning.
In an adenoid cystic carcinoma, if your resection is R2 or R1, is it safe to resect trachea and follow it with radiotherapy?
Why not? This usually, invariably, they are large tumors causing obstruction. So we know that they can recur. When they recur, we can always palliate them, fulgurate them, and look after them. But if you leave a big tumor causing complete obstruction of the trachea or bronchi for the matter, the patient will progressively become more dyspneic and die. So you can do surgery and follow it up with palliative measures.
And what are the strategies in subglottic stenosis in children?
I have not had the opportunity to do subglottic, the same principle. You know, they usually have a laryngotracheal course were conducted by Walter Klepetko in Vienna. Rajiv and I have attended 3 of their meetings. This meeting we could not go because of the coronavirus. So they have a dedicated team. I'm sure you would have been to Vienna, to Klepetko's place.
Yes, sir.
They have a dedicated team of pediatric ENT surgeons and pediatric thoracic surgeons who do it together. And of course, the same principle holds good. I usually, when it is an infant and a child, I involve an ENT surgeon as well, because most of them go to them and they involve you. It is like that. one Dr. Balaji, who has done all the cases with me from me. And I also, at this point of time, want to thank all my anesthetists, Dr. Bhaskar, Dr. Naidu, Dr. Janagiram, and who had helped me throughout my career, and Dr. Satya now. It is a big team game. And the assistants, the associates, Dr. Sashank has been there from the first case till the time in 2005. And now, of course, Roy Nyanamuthu was there, now Rajiv is there. You need a good team. As you get older, you can do only a little time in the operation theatre. After that, you start getting. So you have, once you have a good team with you, you can go on for a much longer time, provided God gives you good eyes and good hands. So that's what I feel. For older surgeons to hand over the modern things to the younger surgeons. They are much better than you that way. You don't try to learn. I tried to learn wax surgery. I knew that once Rajiv started moving, he was much faster and better. And of course, Zamir was there always telling me to keep away, in that aspect. But, it's important. It is difficult for the surgeon to give away what he gets to the next person. Being a son, it is very easy for me. For others, it becomes even more difficult. But you have to do it if you have to produce.
Very important, sir. Very good point. Sir, can pericardium be used to cover loss of trachea?
Pericardium, the problem in pericardium is if it is less than 1 centimeter, half a centimeter, you can patch it. But if you have a large circumference of trachea, if you put a pericardium, it will flap. Even though you put glutaraldehyde, still it is not as thick. It has not got the thickness. So during inspiration, it will go in. And later, it will get, at the site of anastomosis, you can still get granulation. Tracheal surgery, you have to use God-given trachea as far as possible. Whatever else you can try to use, because they always have limitations.
And do you consider neck radiation a contraindication to tracheal surgery?
Neck irradiation can cause severe thickening of the trachea, like the case you said, and loss of tissue plane. So it makes tracheal surgery definitely more difficult, like redo lung surgery after radiation. There is no plane between the vessels and the trachea. We have all seen that. The same point holds good in the trachea as well.
Sure. And is there a specific age to operate in congenital tracheal stenosis?
Congenital tracheal stenosis, as early as they become symptomatic and they have difficulty in breathing, you have to do it. You have to do it, and as I told you, there are dedicated centers to do it. The infant cases I've done with the pediatric cardiac surgeon, Dr. Neville, in Apollo. So we need a team even for that.
I'll ask the last question, sir. It's from a young surgeon who's saying, if we are stuck in a place where there is no backup, how do we go about surgery for tracheal innominate fistula? Could you please
just put a stent and be done away? The best thing is to put a stent. If you're not able to put a stent, you have to do the surgery. You have to get the ascending aorta. You have to get the distal innominate artery, tape it, make a shunt between the, have a temporary shunt, the Prohit Inara shunt, or 2 Foley's catheter, and connect it, which I've done in the GH. And then you do the anastomosis and tie the innominator. That's the only thing you have to do it. Because if you don't do it, the patient is definitely going to die. You have to explain the risk, tell the relatives, and go ahead.
And how close are we to a tracheal prosthesis?
So far,
what is the literature?
All the 3 meetings I've been there, very bad results. They have been. I was looking forward to the new meeting to see if anything new has come. They've tried all sorts of things. They have tried a lot of things. Homographs. They have tried skin flaps with cartilage in between, trying to vascularize it. But all of them have been a failure.
So that was a very, very interesting and very informative session, sir. I have covered all the questions from the audience. Thank you very much for your time, sir. It's been an honor to have moderated this session with you. And I have to say, I don't know about the juniors, but I learned a lot for sure. Thank you very much, sir. And please keep safe. And we'll keep in touch. Hopefully, we should meet up soon, sir.
Hopefully, be safe, Zamir. Take care. I'm happy you can stay at home. You and your wife take care of your family. All the guys around, take care. This is going to pass off after some time, but all of us have to be patient. Never overdo anything and get into trouble. Of course, the older guys have to sit at home. The younger guys have to work, but protect yourself. Take care and God bless. I enjoyed this session very much and it was wonderful. Thanks, Zamir. God bless and take care. Thank you.
Thank you. Thank you very much and good night, sir. Good night.